Thank you very much. Thank you. And oh my God, you're all so far away. I feel I want to call you up here, but thank you for inviting me today. I'm really pleased to be here. I'm just reflecting on the previous talk, thinking it's actually it's a real honor to be able to talk about aging with HIV. Because the fact that people are aging means that people are surviving and people are getting access to good therapy. And the one thing I really hope is that in 5 years' time, I will still be able to do that talk. And obviously with the recent changes, which are affecting some parts of the world more than others, I mean, that sort of is a little bit questionable at the moment. So I just want to start by reflecting on that fact. Now, the other thing is I'm a statistician, as you've heard, so I hope you'll bear with me because I want to perhaps put a little bit of methodology into this talk. So it's not going to be overly clinical, but I want to question what we define, particularly when we think about multimorbidity, and think about sort of some of the implications for that for people living with HIV. So firstly, some disclosures for me. Just to put this into context then, why am I talking about aging? Well, these are our data from the UK. We're in a very privileged position in the UK. You can see from this that over time, the proportion of people who are living, who are in their 50s and older than that, has increased quite dramatically. And that's the bars in turquoise blue and dark blue on this slide here. Now, we're in a position now where over half of the people living with HIV in the country are in this age group. I thank the local team here for sharing some local slides with me. I can see certainly that in the Asia-Pacific area as a whole, there's also been this increased proportion of people in the older age groups. As you can see with the shift in those bars on this slide, shifting upwards as the population is aging. It's a little bit different, as we can see here in Thailand. On the left there, you can see the age at the time of ART initiation, which, at least for the last few years, has been synonymous with the age at diagnosis. And you can see that over time, whilst the proportion of people who are older at the time of age diagnosis and starting treatment has increased a little bit, there's also still an increased proportion of people in that younger age group. So people are continuing to acquire HIV at quite young ages. And of course, when you then look at the overall age distribution over time, that means that although many people are surviving and are getting older, there is this constant influx of new people who are younger. But nonetheless, if you look on the right-hand side there, there's around 27% of people who are older with HIV. So I think most areas, at least now, most areas are continuing to see a group of people that's aging. Now, of course, again, reflecting the success of that, what does that mean? Well, as people get older, regardless of whether they're living with HIV or not, they are increasingly susceptible to a range of age-related comorbidities. And again, looking at the UK, you can see there that we had, certainly a few years ago, very high rates of people with dyslipidemia, with type 2 diabetes, cardiovascular disease, renal impairment, hypertension. All very common complaints amongst an older population of people, regardless of their HIV status. But what you can also see on the right-hand side is that as people got older, the proportion of, or the number of those conditions that they were living with was increasing. And this is another slide that shows the same sort of thing. This was probably one of the first studies to report this. It's a study from the AIDS HIV cohort in the Netherlands, showing again that amongst people with HIV as they got older, the proportion or the number of conditions they were experiencing increased. But importantly from this, they also reported that a person with HIV who was aged 45 to 50, say, which is the group that's got a bar around it, their characteristics in terms of comorbidities were more similar to a person without HIV who was perhaps 5 to 10 years older. So already starting to suggest that amongst those with HIV, there was a higher rate of these comorbidities. And of course, these were the first studies that then started us to really look into comorbidity development, to look at the contribution of HIV to those events. Now, going forward, with the caveat that I mentioned earlier about changes in the current climate, but going forward, there is certainly projections that the comorbidity prevalence then is going to increase. These are US data. They're from a mathematical model called the Pearl model, published by Kerry Olthoff and colleagues. And what she did was she projected forward the incidence or the prevalence of a range of comorbidities. It's a bit hard to separate them out on the slide, but anxiety and depression, kidney disease, dyslipidemia, diabetes, hypertension, the comorbidities I've already been talking about. And what they showed through this model, that over time, the prevalence of most of those comorbidities is likely to increase. And that, again, is reflecting the aging of the population. But perhaps importantly for my interest and with the direction that this talk is going to head in, when they then looked separately by different groups, they could see that the projections were quite different. And I'm only showing the women here, but women, different ethnicities, women who injected drugs and women who didn't. And you can see that for some of those trajectories are going to be quite different. And what's this highlighting to me? Well, it's starting to highlight that there are contributions from other factors that are not just HIV-driven. This starts now, particularly in the US, to bring in social inequalities and the impact of lifestyles and behaviors. And I think we always have to remember those. So I'm talking about multimorbidity. What is multimorbidity? Well, I like this definition. It's from our UK Academy of Medical Sciences, and it's defined as the coexistence of two or more chronic conditions, each of which is either a physical non-communicable disease, a mental health condition, or an infectious disease. And the reason I like this is that it does reflect that mental health is an important part of health, and therefore it should be considered as a comorbidity as well. It also reflects the fact that the group that we're looking at is also increasingly susceptible to infections, and so it brings those into the definition. Now, we also need to reflect on the fact that when we're looking at people with HIV as a population, whereas the general terminology here, let's see if I can, press the right button, that one. No, you're not going to see it. So on the left-hand side there, you can see that that definition of multimorbidity really assumes that HIV is just one of many infections, comorbidities that someone may have. But within our context, whenever we talk about multimorbidity, we are always talking about multimorbidities within the context of HIV as an index condition. And so that strict definition itself, if you applied it as it is, would suggest that for anyone with HIV, they only need one more comorbidity, and that then puts them in that category of multimorbidity. But in fact, when we think about multimorbidity, we tend to focus with the right-hand side here. So we say, excluding HIV, someone with multimorbidity generally has two other conditions. So I think there's a distinction there because, of course, when we then look at the general population, that's very different. So how prevalent is multimorbidity? So I've just got a few slides on this. The first is from a US medical pharmacy claims database. The authors within this study considered a range of 67 different conditions. They had a whole long list, and then anyone with at least two of those was defined as having multimorbidity. And what you can see from this, firstly, as we would expect, as age increases, the proportion of people with multimorbidity increases. But it actually was very high overall at around 50.7%. So over half of the people in this claims database had multimorbidity. But actually, if you looked at the people without HIV, it was also high because it was 42.1%. So multimorbidity is common, but it's common in everybody as they get older, and particularly people who are accessing healthcare services. There's a reason why they're there. It's because they're sick, and therefore multimorbidity is common. Now, two more studies that have looked. The first was a study in southwestern France. They considered 5 different conditions: chronic renal failure, cardiovascular disease, hypertension, diabetes, and cancer. And they defined multimorbidity as at least 2 of those. Of their study of almost 1,000 people, just around a quarter had multimorbidity. And then a third one, which is from the UK, which is a cohort of people of Black African ethnicity living in the UK, attending 9 clinics. They use a similar definition, 6 different conditions there, but you can see there's some overlap, particularly in terms of cardiovascular disease and diabetes. It was a smaller study, but around half of people in that study had multimorbidity. Now, if you compare that to the previous slide with the US study, you can see that very, very different definitions there. But in fact, in this definition, which included only 6 conditions, is actually a higher proportion of people with multimorbidity. And I think what this has really introduced to us was the fact that the definition itself, although it's conceptually very simple, how people apply it is hugely different. And you can look from study to study, and every definition is different. So with that in mind, we actually then reviewed those definitions. And this is a slide from my research assistant, Lux Sukumaran, who looked at 22 studies that had reported on multimorbidity in people with HIV. And she found that when you looked at the definitions itself, the number of conditions considered within that definition was quite different, from less than 10 in around half of the definitions to more than 30 in one, which was presumably the slide I showed you earlier. But not only that, the definition, the threshold for multimorbidity varied from study to study, and the approach taken varied from studies which just counted up the number of events to studies that used weighted indexes like the Charlson comorbidity score, but to other studies that used much more of a statistical approach. So just confirming what we knew, that the actual definitions themselves were quite different, but also the conditions that were included were quite different. So whereas you'll see from this that cardiovascular disease, metabolic disease, urogenital disease very commonly were included, actually as you go down, some other conditions like skin problems, infections, eye, ear, nose, throat conditions were much less frequently captured in those definitions. And what might be a little bit harder to see from this was the actual conditions themselves were also different. So even if cardiovascular disease was included in the definition, what the authors meant and considered by cardiovascular disease was quite different. So hypertension and stroke were very, very common, but something like atrial fibrillation, say, was much, much less common. And again, the very different definitions there. So one of the reflections of that was that basically most definitions of multimorbidity were just based typically on the total number of comorbidities present. But of course, just by counting up the number of conditions doesn't really capture the burden. And what you might find is that someone who has 2 very different conditions has a much bigger health burden, or it's much more costly to the health system than someone who has 2 conditions that are actually fairly similar. So what that drove us to do was to have a look within our aging cohort of people with HIV to see if we could see any patterns. And this was the figure that we found. This was a principal components analysis trying to sort of identify linkages and clustering as well. And we could see that the conditions didn't occur randomly. So they did occur together. There would be people who tended to have the same conditions. So you can see on the top right there, there's a big cluster of cardiovascular metabolic type conditions there. So someone with hypertension, say, was more likely to have one of those other conditions as well. We can also see, I'm trying to see on here, on the top left of the slide, a cluster that was really around mental health problems. We had a cluster of sexually transmitted infections, which is not surprising given the fact that's driven by lifestyles. We had clusters of cancers, so people who tended to have cancers might be more likely to have another cancer. And of course, these clusters are reflecting the fact that there are common risk factors. There's things that are driving many of those conditions, and they share etiologies, they share those risks. But what that then allowed us to do was say, well, can we now look at measuring a burden for somebody within each of those clustering areas. And so we then use that information to generate a series of scores for each person, which would tell us a little bit about how much more likely that person was to have a heavy burden of disease within that area compared to somebody else within the cohort. And so on this figure here, you can see that anyone with high scores were more had a heavier burden of disease within, say, the cardiovascular, within the neurometabolic focuses than other people in the cohort. And that gives us a way now to try to look at risk factors for those morbidities. Okay, so let me move on a little bit now. Let me think about the contributors to ultimately multimorbidity, but morbidity initially. So I want to start by thinking about, if we think just about one condition, morbidity, what would those risk factors be? Well, for those of us in the room, most of us have a focus on HIV itself. That's what we're researching into. And so we are thinking about things like inflammation, immune activation, all of those biological pathways that HIV may drive. But of course, we're also focusing on antiretroviral toxicities. I have spent much of the last 20 years looking at cardiovascular outcomes, but other toxicities, particularly more recently in terms of weight gain, they may play a role. But we also have to remember that people are aging, so many of these conditions would occur anyway, so we have that general aging pattern, and that may differ depending on whether you're a man or a woman. It may depend on your ethnic origin. And then we have a whole series of factors that could contribute, which will relate to lifestyle. So it will be substance use, so particularly alcohol, smoking, recreational drug use. I've talked already about obesity and diet, but we know that obesity and diet contribute to many, many morbidities out there. And then a factor that I think has perhaps only recently been started to take seriously is sleep patterns and the contribution that poor sleep plays, particularly to some of those metabolic conditions. Then we have socioeconomic status. Many of our cohorts are people who are really severely affected. They're living in very low socioeconomic conditions, in poverty. They may have very poor living conditions. Many people are also living with a condition that is highly stigmatized, and that will introduce stress, which itself will contribute. We then have polypharmacy. And this is an interesting one because multimorbidity drives polypharmacy. Polypharmacy itself has been hypothesized to contribute to more morbidity development. So there's a vicious cycle there that the more treatments, the more comorbidities. And then this is not necessarily a cause, but it's something we need to be aware of. If we look for something, we're more likely to find it. And many of our cohorts are very well monitored, and therefore we start to detect some of these comorbidities much sooner than someone in the general population who may not engage very well with their health care. So all of these factors may contribute. But what if we look at specific conditions? Do they all contribute to the same degree? Well, if we look at cardiovascular disease, I think we might argue that many of those factors probably do. Most of them will contribute in some way. But if we move to something like liver disease, say, then maybe that is mainly driven by substance use, maybe injection drug use, also obesity and diet at the moment, and socioeconomic status. But the HIV contribution may be relatively small to that. And then if we look at lung cancer, say, then the big driver of that is tobacco, cigarette smoking. May also relate to stigma and stress and socioeconomic status that then drives the smoking further. But there are now, you can start to see different contributors to different morbidities. And so, of course, my question is, when we start to look at multimorbidity, what would we even expect to see? Because these will start to cancel each other out, and we aren't going to see the factors that we want to see. So I think we're almost setting ourselves up for failure here. Now, one of the things we did do with those scores was we had a look at whether we could see if there were factors that were driving each of them. And we could see that certain factors were consistent. So older age, for example, was associated with worse cardiovascular disease, with the neurometabolic disease, with cancers. But whereas male sex was associated with cardiovascular disease, neurometabolic disease, it wasn't for the mental gastro-joint conditions, where it was female gender that was more prevalent. So you can see already when we start to look now, we're getting different risk factors for different conditions. So trying to find a unique set of factors that drive multimorbidity is going to be challenging. Now, if you add on to the fact that for many of the studies, we don't even look at most of those conditions. And I think if you review the literature, what you'll see is that most studies are going to focus on those HIV factors. They'll focus on the biomarkers. They'll focus on the inflammation, say. They might include age and sex and a few demographics, and they might capture substance use. But very rarely do they measure sleep patterns. Very rarely do they measure stigma and some of those other drivers. So we're only seeing half of the story when we look at risk factors for contributions to morbidity. Just as a couple of examples here, this was a Moroccan study that was looked at people who are predominantly male, average age around 50 years. And in their study, they looked at age, they looked at gender, they looked at sexual orientation, smoking status, all of the standard factors that we would capture, particularly duration of infection, CD4 counts, viral loads, etc. And many of those factors were associated with morbidity. But they didn't look at some of the other drivers that may play a bigger role, so some of those socioeconomic factors. This was a New York City study that looked at similar sort of definitions, number of comorbidities. This was a study that looked at the count of comorbidities, and they then separated them onto ones that were considered to be high risk in that they were really associated with a higher mortality risk. But some also which had a big impact on someone's ability to function. And again, most of the factors they looked at were essentially the older age, the sex of the person, their sexuality, longer duration of infection, and their ethnicity. Very little in there that was really capturing those socioeconomic factors, apart from perhaps looking at transgender status within that. And ethnicity, which is also probably going to reflect social inequalities within New York. So those studies are not capturing really any of those factors. And yet some of those factors are really important. And this is going back to that African study in the UK, where we looked within that at multimorbidity defined on 6 different conditions. But what the authors of that study also did then was look at several measures of poverty within the population. And remember, this is a population in the UK where we have access to free healthcare. So in theory, you don't think there should be many social inequalities. So they looked at food insecurity, they looked at employment insecurity, financial insecurity, loneliness, isolation, and those factors there. And they were able to, again, use a similar sort of principal components clustering analysis type approach that allowed them to capture all of that information within 3 variables. One which measured somebody's livelihood, so how much money they had, how many resources they had. One which measured their living status, so their shelter displacement, and one that really captured whether someone was isolated and alone. And importantly, all 3 of those were really strongly associated with multimorbidity after they controlled for the demographics, suggesting that there are factors here that we don't measure which probably are driving a lot of those comorbidities. And then if we look at the comorbidities themselves, this was the slide I showed earlier from Lux's review, looking at the different comorbidities that are often included in these definitions. But are these the comorbidities that are important to people living with HIV? And the answer is no. And this was a very small qualitative study. It's a few years old now, but people themselves were asked, what factors concern you? What are you worried about? And they weren't worried about cardiovascular disease, really, or cancers. They were worried about pain, gastro symptoms, fatigue, frailty, all of these more symptomatic things, conditions, rather than actual heart diseases. But very few of our definitions of multimorbidity really capture some of these things. So what we have is we have a group of comorbidities that are not really reflecting what people worry about. We have a group of factors that are not necessarily capturing the things that really drive multimorbidity within this population. So we have a disconnect there between what we're doing as researchers and perhaps what people are really worried about. And, you know, I looked and I thought, why is that? Well, I mean, it reflects the fact that for many of us, we focus very much on this biomedical model. So we focus very much on biological pathways, things that we understand, things that we know about, because why? Well, we can do something about it. So if you can identify a biological pathway, you might be able to identify a treatment that can solve that. Whereas if you identify that it's basically poverty that is driving the multimorbidity, there's very little you can really do to alleviate that. So essentially, we're studying these because we can and because we know what we can do with them. But of course, this is a very expensive model, and actually maybe potentially around in the Asia-Pacific, in Thailand, perhaps there's less focus on these factors here because of your tradition, perhaps of a bit more holistic medicine. But I think that many of us in Europe, in North America, may perhaps also need to reflect on that a bit, that there are other things going on that perhaps are greater contributors. So I'm going to finish there. I can see I've got 3 minutes. So really, because of treatment, effective treatment, multimorbidity is a challenge that many people living with HIV will have to face. This is a good thing. And we always think about multimorbidity as a negative thing, but actually it is reflecting the fact that people are surviving, people are living longer lives and conducting the lives that they should have. So this is what we would expect to see in many cases. It's very difficult to look and compare studies of multimorbidity because everybody has looked at this in a different way. But I think what we've done is we've tended to focus very much on a limited range of risk factors, and they're not often the risk factors that really contribute most to many of the morbidity that is going on there. So if we are really ever to try to bring people's health so they have optimum quality of life, I think what we have to start doing is have to reflecting on some of those other factors that are driving this, particularly the stigmatization, the poverty, the other lifestyle factors that may contribute. And of course, just reflecting healthcare systems, we also need to make sure that healthcare systems are prepared for this, because this will hopefully continue to increase in prevalence. Healthcare systems do need to be prepared. They need to be able to support that rather complex needs of people with HIV as they age. And I'm just going to leave it there, so thank you very much for listening.